Hi students, welcome to the next session in oral pathology. Okay, so far we have discussed the benign and malignant tumors of the salivary gland. Now there is another section of lesions in salivary glands which are neither benign tumors or malignant tumors, but you can see swellings or you can see lesions in the salivary gland. Okay, because of some other reasons other than your neoplasm. Okay, so those things will be discussed here, and this is very easy area and easy topic. There are certain few facts or few concepts here that we should understand. Okay, so let's start with your non-neoplastic lesions. Okay, non-neoplastic lesions, I'm going to start. So what are the reasons which can cause salivary gland enlargement? Salivary gland enlargement. So salivary gland can be enlarged in your tumors. Though, so we have seen all the tumors that we are not going to do. Okay, benign or the malignant tumors, that's we have already done. Now, what are the other reasons other than these tumors? What are the reasons where this salivary gland is enlarged? So if the salivary gland has some inflammation, okay, inflammatory enlargement, inflammation, that condition is called sialadenitis. Itis is something we use for your inflammation. So sialadenitis is an inflammation of salivary gland. If we get an inflammation, mainly inflammation can be either due to viral infections. Okay, viral infections, or it can due to bacterial infections. Okay, so viral infections, one of the most common viral infection of the salivary gland, that is your mumps. You can see that is caused by your paramyxovirus. Okay, so that mumps can cause enlargement, bilateral enlargement of salivary gland. Usually it comes in the children, right? The other one is bacterial infection is due to mainly your staphylococcus aureus bacteria. It can cause enlargement. We will see sialadenitis. Other than this inflammation, okay, what are the other condition where you can see the salivary gland is enlarged? Okay, it is neither due to tumor nor due to inflammation. So there are some conditions where you can see non-inflammatory, non-neoplastic enlargement. Means there is no inflammation, non-inflammatory, and non-neoplastic. Means there is no neoplasm, no tumor, no inflammation, but still the salivary gland appears to be enlarged. So there are certain conditions. You can see that in pregnancy. Okay, in pregnancy, sometimes you can see in have you seen alcoholic people? They have a puffy cheeks, right? So alcohol consumption, alcoholics, they have a puffy cheeks because of this non-neoplastic, non-inflammatory enlargement. We call it by the term cialosis. So cialosis is the term for non-inflammatory, non-neoplastic enlargement. Okay, alcoholics, and in some malnutrition cases, in diabetic people, you can see that this enlarged salivary gland is enlarged. If they are having drugs for BP, anti-hypertensive drugs, okay, anti-hypertensive drugs, okay, anti-hypertensive drugs they can have. Then hypothyroid patient. So, these are certain conditions. These are certain non-neoplastic, non-inflammatory origin, that is cialosis. Now let's take sialadenitis. Sialadenitis. Now, what is the features of sialadenitis? Sialadenitis is that it is inflammation of the salivary gland. And what are the two reasons? So one, it can be either be viral infection or it can be bacterial infection. Now, how can you differentiate whether it is a bacterial sialadenitis or viral sialadenitis? How can you differentiate? You know that bacterial sialadenitis and viral sialadenitis differ in a major thing, which causes pus. Okay, so if you have swelling in the salivary gland, if the patient is coming with swelling in the salivary gland and you palpate the gland and you can see that pus is coming through the duct. Okay, you see the oral cavity. Parotid gland is there. Okay, you can see the parotid gland and the duct opens near the molar tooth, and you palpate the gland and you see that pus is coming out. If pus is present, that is suppuration is there, it is mainly bacterial. So bacteria mainly your staphylococcus aureus. Staphylococcus aureus is the main causative, and there is suppuration. suppuration is there, pus is found, pus is there. Okay, but viral mostly it is caused by your mumps virus, and there is no suppuration. It doesn't produce any pus. Okay, there will be swelling. Okay, there will be swelling, but there is no suppuration, and you can do a lab test to whether to see whether it is bacterial or viral. So if it is a bacterial, you can see that the serum amylase test can be done to identify which is viral. In viral conditions, it will be increased. The serum amylase will be increased, while serum amylase will be normal in bacterial. Okay, serum amylase will then values will be normal in bacterial. So this is the main difference between your viral C. alanitis and bacterial C. alanitis. And there is a infection or inflammation of your salivary gland duct. What will we call the term whether when the duct is inflamed? Ductal inflammation. Only your duct is inflamed. Ductal inflammation, if only the duct is inflamed, we call it by the term sialodochitis. Sialodochitis. These terms are very important because they ask you in your exam. Okay, when we are doing, there's a technique called sialography. Sialography is a technique to identify the pathologies in salivary gland. So how to take a radiograph in salivary gland? You know that salivary gland is a soft tissue, so we cannot take a radiograph. So to make it radio opaque, we put some radio opaque dye into it, and we take a radiograph. So that procedure is called a sialography. And sialographic appearance is a very favorite question, very famous questions in your NEET and INICT. Okay, you can get a lot of questions in sialography. That we will discuss. We have a video on sialography and what are the different appearance. I have made a chart, or I made a table for you to see what are the sialographic appearance in different lesions. Okay, so this is sialodochitis. Sialodochitis is the inflammation of your ductal system. Okay, salivary ductal system. So now you are familiar with the sialadenitis and sialodochitis. Now I want to discuss a topic called mucocele. Mucocele. See, mucocele is an old term, and actually we are not supposed to use this term now. Mucocele is an old concept. Okay, mucocele. Now, actually, mucocele is of two types. The present scenario, mucocele is told as extravasation and retention. It is two types. So mostly the mucocele is a cystic swelling. Mucocele is a swelling. It's a swelling due to your pooling of saliva. Okay, this is what it is due to pooling of saliva. So it's a swelling which is produced due to pooling of saliva. Now, you know that when a saliva is produced, you have an acini here, you have a ductal system here. So we have an acini and we have a ductal system. So if the duct is tampered or damaged, okay, if the duct is damaged, what happens? This saliva will come out here, and it will pool in the connective tissue. Right, it will make a pool in the connective tissue. The saliva will pool in the connective tissue. So it is coming out of the duct. It is coming out of the duct due to trauma. Okay, so any trauma to the duct. Okay, any trauma to the duct can cause the saliva to come out. That is called extravasation. 80% of the cases it is due to trauma, and 80% of the cases it is extravasation. So we call it mucus escape phenomenon. Mucus escape phenomenon or mucus extravasation phenomenon. So mucocele is a vague term. Okay, mucocele is a vague term. What happens here is the trauma to the duct, and the saliva comes out. 80% of the cases, this trauma, due to the trauma, the duct is tampered and it comes out. The mucus escape out from the vessel. So that is from the duct. That is through the tube it is going. It is escaping out. That is extravasation. And 20% or 15 to 20% of the cases, what happens is that the duct will be okay, and what happens is that the duct will be obstructed by a stone. Okay, so ductal obstruction happens here. What happens when there is ductal obstruction? The duct is blocked, and when the duct is blocked, what happens? The saliva which is coming out from here, it will bulge. It will make a bulge there. okay, because of this obstruction. The duct is obstructed by this stone here, and it will make a bulge over there, make a swelling over there. That is called a mucus retention phenomenon. Okay, that is mucus retention. Mucus retention phenomenon. Okay, so mucocele can be either mucus extravasation phenomenon or mucus retention phenomenon based on what type of what trauma they are happening. If it is a break in the duct, it is escaping out, and if it is cyalolith, a stone or some blockade in the duct, it is mucus retention. So anyway, we consider it as a mostly it is extravasation. Okay, mostly it is an extravasation, and what happens, we consider mucocele as a pseudocyst. Okay, because there is no lining for this is just a mucus pooling in the connective tissue. Okay, so that is the concept of mucocele and how it will clinically appear. Show you how it will clinically appear. Okay, you see this picture. Okay, you have a swelling in the lip. Okay, swelling in the lip region. That is because mainly because of the minor salivary gland. Any trauma may have happened to the salivary gland. So all the mucin or all the salivary production has been come to the connective tissue, and it is making a soft fluctuant swelling. Okay, soft fluctuant. So it is just like a balloon with water, right? It is very soft, very fluctuant. It is full of water, that mucinous water. Okay, that is soft fluctuant swelling. And when it comes in the floor of mouth, when such a lesion comes in the floor of mouth, we call it ranula. Okay, we call it ranula. When this happens in the sublingual glands, okay, when the blockade happens in the sublingual gland, that is which is present below the tongue. Okay, sublingual gland, if the duct get blocked, and it will cause a big large swelling, or if the duct is damaged to the trauma, mucus will come out and it will fill up the floor of mouth. So if this mucocele, the phenomenon of mucocele occur in the floor of mouth, we call it ranula. Ranula, why we call it? It is like a frog's belly. A frog's belly. Ranula is something related to frog. So frog's belly, it denotes frog's belly. So it is so smooth, bluish, like a frog's belly. Okay, it is bluish, soft, bluish in color, right? This is due to that vessels there. Okay, can you see that? This is in the picture. So this is the concept of mucocele. Okay, this is the concept of mucocele. And there is no much thing you should learn about the histology of mucocele or something. Okay, you should understand what is ranula, what is mucocele. No? Okay, this is the concept. Okay, now one more thing, one more important non-neoplastic lesion which they usually ask in the exam is your necrotizing cyalometaplasia. Okay, so I think from the name itself, now you may understand what is necrotizing, what is cyalo, what is metaplasia. Okay, some kind of necrosis is happening here. Cyalo means something related to salivary gland. Metaplasia, what is metaplasia? Metaplasia is the phenomenon by which a differentiated cell, one differentiated cell transformed to another differentiated cell. That is metaplasia, right? So here what happens? This usually happens in a smoker. Okay, when a person is smoking, usually in reverse smoking. Okay, usually in reverse smoking. So when a person is smoking, reverse smoking, you know that the person keeps the butt and a lit end in the inside the mouth, and then he is smoking. So what happens due to the heat and the smoke? Okay, due to the heat and the smoke, the minor salivary glands, okay, the minor salivary gland in the palate, on your hair palate, they get necrosed. They get necrosed. What necrosed? Due to the heat and the smoke. Okay, so the minor salivary glands in the palate, they get necrosed. That's why the term necrotizing. Okay, so to cause to break this heat, to withstand this heat, what happens? The salivary gland will change their lining epithelium, and means they will change their acinar structure. Okay, so the minor salivary gland, they contain mucinous cells, serous cells, etc. So due to this heat, what happens there? The mucus cells or the acinar cells, okay, acinar cells, they cannot withstand much heat. They will transform, or they undergo metaplasia. They undergo metaplasia to a cell which can withstand heat. Okay, so you know, in the oral cavity you can eat hot food. Okay, you can eat little hot food. our oral cavity, the epithelium will withstand a little amount of heat, right? So they will transform to squamous cells. Why they are transforming to squamous cell? Because to withstand this heat, to resist this heat. So that happens here. That is metaplasia. So necrotizing cyalometaplasia. So due to reverse smoking, due to the heat and smoke, the minor salivary glands of the palate, they get necrosed, they have ischemia, and what happens, they get necrosed, and that area of necrosis, okay, that area's necrosis will look like a punched out lesion. See, ulcer. Okay, punched out ulcer. I can show you the image here. Okay, can you see this picture? This is a very important IBQ, image based question. Okay, this is an image based question. You can see a ulcer, a large ulcer which is having punched out ulcer on the palate, and it will look like squamous cell carcinoma. It will look like a squamous cell carcinoma, right? It will look like a squamous cell carcinoma, but it is not. But it is not. So this is how they ask you question. This is how they compare and ask you question, which look like a squamous cell carcinoma, which give appearance of a squamous cell carcinoma clinically. Okay, but the patient is a smoker. So a person coming to you with a large crateriform ulcer on the palate, which look like a squamous cell carcinoma. Okay, and this person has a history of smoking. Okay, so this is how necrotizing cyalometaplasia. This is necrotizing cyalometaplasia. Okay, necrotizing cyalometaplasia. Okay, look like. This is how it look like. And what happens in the histology, if you take the biopsy, I'm going to take the biopsy. I'm not sure whether it is necrotizing cyalometaplasia or a squamous cell carcinoma. What I'm going to do, I'm going to take the biopsy of the lesion. Okay, and I'm going to see what is there in the histology. So in the histology, what I can see metaplasia. Metaplasia means I can see that this was the acini where I had a good acini. This was a normal cell with acini. Okay, this was the acini one. This was a normal salivary gland. Now what they have undergone? They have undergone metaplasia, and what happens instead of this mucous cell, I have squamous cells there. Okay, I have squamous cells, flat cells which is not secreting anything. They are transformed to squamous cells, and in the center I can see so much of keratin. Okay, I can see so much of keratin. Why this keratin is formed? Keratin, you know that keratin on your skin, on your oral mucosa, they will withstand forces. They can withstand insult. Okay, they can withstand the heat, they can withstand the forces. So the body will automatically try to compensate for this heat. Okay, so this is called a necrotizing cyalometaplasia, and the phenomena is occurring. What is occurring here? There is squamous metaplasia. Okay, squamous metaplasia. So this is about your necrotizing cyalometaplasia. And one last point about your cyalolith. Cyalolith, or we say cyalolithiasis. So many terms they have used for this cyalolith. Now what about cyalolith is that cyalolith is the calcification or calcified deposits in the ducts of the salivary gland. Okay, calcified deposits in the ducts of salivary gland. So that is cyalolith. Now, what to learn in the cyalolith is that in cyalolith, I will write it here, cyalolith. Okay. So those are calcified deposits. Okay, calcified deposits. Now, what is the main reason and where the cyaloliths is commonly seen? Cyaloliths are mostly commonly seen in the duct of your submandibular gland. So most commonly that is seen in the duct of submandibular gland, and you know the name of the duct, that is your Warthen's duct. Okay, Warthen's duct is the duct of your salivary gland. Stensen's duct is your duct of your parotid. So Warthen's duct is the main duct where you can see the cyalolith. Right now, why cyalolith usually occurs in the Warthen ducts? So there is so many reasons they list out. I think this is pure basics. The salivary gland of so submandibular salivary gland secretion is more mucinous. Okay, so it is very thick. So the flow is limited, so that there is chance that the saliva get pooled there and make a get it calcified. Okay, the duct is tortuous. Tortuous means the duct is not straight, it is wavy and wavy, so that there is so many stops in between, and this can act as a dent or a bend where the mucin can pull off and it can get calcified. Okay, and duct is to upward course, towards a upward course means uh, means if the salivary gland is here, okay, if the submandibular salivary gland is here, the duct is towards upwards. So it is chance that due to gravity, what happens, the saliva get pooled and it can cause a what stone formation, right? So these are certain reasons for the formation of cealolith more in the submandibular gland. Now, there are certain questions, concept based question in this. Okay, does the formation of cealolith related to the serum calcium? So a person is having more of calcium. Will he get a cealolith? Okay, so that is one question. This is not related. Okay, the cealolith is not related to your serum calcium. It doesn't matter. There is no relation of serum calcium with cealolith. It is not related to your serum phosphorus. Okay. There's no problem whether you have a high serum or high serum calcium or high serum phosphorus. There's no relation with your cealolith, but they have a relation. It is related to your serum uric acid. Okay, serum uric acid levels. So this, please note, these are certain concepts. They can ask you statement based question, which among the following statement is true regarding a cealolith. Okay, so it is related to a serum calcium, it is related to a serum phosphorus, it is related to uric acid. So what is the right answer is that it is related to uric acid, but there is no relation with the serum calcium or phosphorus. So this is one thing. And they have asked question in about the treatment. Before that, I will show you the photo clinical picture of cealolith, how it will look like. Okay, can you see this picture? Okay, this is the white white area here. You see here the white thing there. That is a cealolith which has blocked the duct. And if you take a radiograph, you can see that calcification here. You know that in the radiograph, calcification will appear radio opaque, right? This is an occlusal radiograph we have taken, and you can see that the calcified area is seen there. Okay, so you can see that cealolith. This is an occlusal radiograph. Okay, for cealolith. Now they have asked question regarding the treatment of cealolith. How can you treat cealolith? Okay, cealolith. There was one question in this treatment. So the best method for treatment of cealolith is that if the stone is very close to the opening, you can palpate it. Palpate with your hands and just push it out. It's called a bimanual palpation. Bimanual palpation. So bimanual palpation is actually you put two fingers inside, two fingers outside. Okay, two hands, two fingers inside and outside, and you palpate the salivary gland, and you make the saliva push out, and you push the stone outside along with the saliva. So this will happen only if the blockade is near to the opening. Okay, so if it is not possible, if it is far from the opening, we can do a lithotripsy. Lithotripsy, that is shockwave lithotripsy. Okay, shockwave. It's actually extracorporeal shockwave lithotripsy. Okay, it doesn't matter. It's a shockwave lithotripsy where you give sound energy and you break the stone into small bits and then you remove it. Okay, that is one thing. But in one of the AIMS INICET question, there was a question about this cealolith, that there is a technique called ceal. Okay, cut.